Good evening for those of us here on the East Coast. Good morning to those of you in the Far East, Australia and New Zealand. For those of you in the Middle East, Europe, and Africa, I have no idea why you're up at this ungodly time, but thank you. East Coasters, again, good evening, and Midwest and West Coast people, good afternoon, and those folks in Hawaii, too. So everybody around the world, thanks for coming by tonight. Imaging for Better Diagnosis, Treatment, and Record Keeping. That's the title of tonight's webinar. And I'm just going to kind of get through this, and we'll go from here. So, who am I? I'm Marty Jablow. I'm America's Dental Technology Coach. You can find me lecturing, writing, and doing all the fun stuff that I get to do in my second full-time job. And if you need to get a hold of me, this is the best way to do it. Marty at dentaltechnologycoach.com. You can also check out my website, dentaltechnologycoach.com, for more information on me. And that's, where we're going tonight. That's the preliminaries. Find me, follow me, whatever you want online, because you can. All right, follow me, Twitter, Facebook, LinkedIn, or my blog, which has lots of good information on lots of varied dental topics, from research to what's the latest and greatest in dental technology. So check that out when you have a chance. I want to thank Air Techniques for sponsoring tonight's webinar. Without them, this would not be possible, so if you get a chance, go check out their website and see what kind of equipment might be right for you. So, where are we going here? All dentistry starts with an accurate diagnosis, because without an accurate diagnosis, what are we doing? That's really what this is about. So we want to get the most accurate diagnosis that we can for each individual patient so that they can get the proper treatment. I mean, that's really what it's all about. And in order to do that, we need good diagnostics. And that comes everything from, being able to see things properly using magnification, good digital radiography, and then we have enhanced devices that allow us to see things in manners that, up until a few years ago, we were not able to do. With that, you want to combine all of the information that you get and take that and make good judgments. Because just because one person looks at something one way and another person looks at another doesn't mean that one's right and one's wrong. That's part of the art of dentistry. And with that comes good diagnostics, because we should never be guessing about what we're doing. We should really just be saying, hey, here's a problem, and here are the various solutions to that problem. And it's real important that we make sure that our diagnostics are real good and verifiable. I'm big on clinical photography. You want to be able to see teeth. You want to be able to document things. I get a lot of information out of photography just by looking at those images on the computer monitor. It's also great for patient education. It's great for your medical legal stuff, and we're going to get into that a little bit later in the webinar. We also have digital radiography here. If you're still using film, that's okay. I mean, at some point you're going to have to jump on board. I was not an early adopter, as most people would think. I had kind of dragged my feet for a while, but I will tell you that I am quite happy that I no longer were dragging my feet, and we've been digital for quite some time now. And with it comes a lot of advantages, which we will go over with, again, a little bit later. I mean, now, what about 3D imaging? We've got cone beam. I mean, look at this. How would you want to be? Would you really want to take out that third molar? I'm sure somebody will, but, that's the kind of information now that we can get that we previously never were able to. I mean, this kind of stuff for implant placement, for third molar extractions, retreating failed endodontics. Cone beam has just really opened our eyes to a whole bunch of different things that we were never able to see before. And again, that's not something run on a mill in every dental office now, but you know it's there, you know it's available if you need it, and it's really something that I rely on more and more. I don't have a cone beam in my office. We have a service that actually comes in a van, and they will come to my office or come to the patient's home or their place of work, and with that, we can get the information that we need. So again, you know, there may not be a reason for you to place it in your office, but that doesn't mean you shouldn't be looking to cone beam as a possible, diagnostic aid when necessary. And then, of course, we have the standard clinical examination. Look and feel in the patient's mouth. Very important, because this is where clinical dentistry starts, right there, with those teeth. And then we get into caries detection imaging. You know, what we can see that we could never see before in different manners that we can. Documented. How deep? Giving us more information than we previously had. I mean, before it was a radiograph, which is a two-dimensional image of a three-dimensional tooth, and now we can actually show caries in ways that just weren't possible before, because in many cases, as we all know, the caries never showed up on the radiograph, but yet it was there, and now we can document it and show it where things are going here. And let's see. I'll be looking at the questions as they come in, everybody. That doesn't mean I can see them as we're going. So just so you know, I will look at them. I'll get to them all, hopefully as we're asking them. But if not, it will be gotten to at the end. We other things too. We're looking at oral cancer. I mean, this is something I get up on a soapbox about this. I think that everyone should be doing an oral cancer examination all the time, every recare visit, looking at a patient. This is a simple way to prevent needless deaths, and here in the United States, a person dies every hour from oral cancer. We need to really take hold of this, and the most important thing is to look. And with that, when we put all of these things together, what we get is documentation. And this is the basis for a lot of your, just your chart. You want to document things. You want to tell people why you're doing it. You don't want to just go ahead and do it. One of the things that I'm big on is diagnosis. When I was in dental school, we really were never taught to put diagnosis into anything. What we did was we wrote, we wrote up our treatment plan, and the assumption was there was caries. And when we got to the chart and we actually did it, we'd write down what we did. But in no place was there a diagnosis. And I'm real big on telling why we're doing things. From a medical legal point of view, you definitely want to document as much as possible, because without that documentation, you can get things like this. This is a request for mediation form from peer review from my state here in New Jersey. And, this is much better than being sued, that's for sure, as peer review. But after going through, been on this peer review committee for 20 plus years, and what do I see? I see horrible record keeping. I see people who've never documented why they're doing anything. It's a rarity. So before you pick up anything, you pick up your handpiece, pick up a scalpel, whatever you're going to do, you want to definitely document the reason you're doing it. So if it is caries, just write down, we're treating this tooth because of distal caries, recurrent decay around an amalgam, recurrent decay around the composite. Tell the reason why. It may save you a trip to peer review, or something like this. I mean, think about this. This is an ad in Kansas City for, an attorney trolling for patients who want to sue their dentist. And the best things that you can do to protect yourself is to have great documentation. And I will tell you, like I said, in all the years of doing peer review, we had one case or 2 cases in 20-something years where we had such superior documentation that it actually saved the dentist. One was a lucky one, the other one, because he just happened to record the right piece of information, but the other one was so well documented that we couldn't find against him. The treatment didn't quite work out, which was something that happens to all of us, me included, but the records were excellent. He had informed the patient along the way of problems, and everything was done, and he had dotted all his I's, crossed all his T's. Patient had signed some consent forms. I mean, it just was the way it was. But you need to have good records, and with that, imaging is a big part to me as to how to get good records and make sure that what you're doing is easily documented. So let's walk through a new patient examination as if you were coming into my office. We will, you'd fill out your forms. I'd introduce myself. We would go through all the, preliminaries. And then we get to this. We start in my office after I've gone through all the review of the paperwork, or in this case the iPad. Digital radiography is where we start. I authorize the assistant to take what radiographs I find necessary. Then either the assistant or myself will do a photographic essay, as I call it. Then I do a clinical examination. If I find areas then that I think may need further look, we go to enhanced caries detection using various different modalities. Then we finish up with an oral cancer screening under white light, and then again an enhanced oral cancer screening. This is my standard new patient exam. So we start with digital radiography, and I have sensors, and I have phosphor plates, and I have these handheld Nomad units in my office, which we absolutely love. Makes taking a full mouth series with a sensor, we can do it probably in about 7 minutes, start to finish. Full mouth series takes a little bit longer time using phosphor plates, strictly because we have to stop and actually put the plates in the machine. But again, 10 minutes, start to finish, full mouth series. We don't schedule extra time and hygiene for those things. When it's necessary and it's time for the patient to have them, we will just include it in the course of their scheduled treatment that day. With digital radiography, we are saving lots of time. We are reducing the radiation to the patient, and overall, it's just a benefit across the board. When we get into these things, we need all this digital imagery, whether it's the radiographs, whether it's the photos, whether it's intraoral cameras, we need to be able to store these images for future reference, whether that be just for diagnostic information or for a medical legal reason. We need to be able to do that. And with that, you come to one of the most important decisions you can make. What imaging software do you want to use? And you're saying, well, what are we talking about here? Well, outside of picking your practice management software, and if I was starting from scratch, actually my imaging software would be the first thing I picked. Then I'd walk back into the practice management software. But your imaging software is something you are going to use all the time, and everyone in your office is going to be using it, from the front desk people to the office manager to the assistants and the hygienist and the dentist themselves. Everyone is going to be looking at this software. And it's a very important decision as to how you want to integrate that. Bridging is one way that's done. And what that does is it's a separate database of your images. And what they do is they actually can read the names and information from your practice management software, so that you're not entering people's names and other demographic information into the imaging software. It's all pulled directly from the practice management software. Some people like this. I do, because it gives me a lot of freedom to use a lot of different devices, different manufacturers. Everything integrates usually better than if you don't have some type of bridging software. Having said that, there are benefits to this tight integration of the imaging software, and that would be based in many cases on what practice management software you are running. An example, if you are someone who runs Henry Schein products such as Dentrix or Easy Dental, you're pretty much for this tight integration where you can see all the x-rays in Dentrix itself. You're locked to DEXIS. That's it. That's your choice. So if you want, any kind of digital imaging, you're going to have to go to DEXIS. Whereas, and same thing, if you're in Patterson Eaglesoft, you're looking at Schick as your solution. Having said that, though, that's where we go back to that bridging. With that, we have the use of different softwares, but they don't quite pop up in the chart. It's a click with the mouse. It's really not a big deal. I've been doing this this way for years. You click a little icon at the bottom, and all the images come up. It's not a hard thing to do. And then you get full-size images, again, depending on whether you want to look at little film strip things across the bottom of your chart. Well, yes, that can be done with these tight integration softwares. But again, there's a million ways to view things. Go out there, look at all the software. They all will integrate with your practice management software. So don't think that you're just locked into those strictly ones with your software. Like I just mentioned, you want to be able to take it across the board, because what may be the best stuff now may not be the best hardware later. In which case, what happens if your new hardware won't integrate with your old? And that's a problem. So what you want to do is you want to really think through this entire discussion of your imaging software. It's a very crucial piece to your office, and it's not one to think about lightly. So when you're making those decisions, like I said, you want to make sure you're picking the right software to go with the right hardware to integrate properly into your office and how you would like it done. There's no right or wrong answer for this. This is strictly a choice, but you want to know where you stand in that choice. Simple enough. When we're talking phosphor plates, one of the benefits are it's basically what I call a digital developer. They look like film, even up to a panoramic film. You can get big ones, so if you have an analog pan, you can continue to use it, and shouldn't be a problem. You're going to use XCP holders just like you always have. These things do wear out, and they do scratch, so you have to be somewhat careful with them. But it's a lot different here. These phosphor plates are somewhere in the neighborhood of $20 a piece. They're not like a digital sensor, which is going to run thousands of dollars to replace. And this might be a very easy way to get started into digital radiography. You can just do what you're doing, and like I said, just consider it the digital developer. You can even put it in the darkroom if it makes sense to do that, and just take it from there. They are diagnostic. They're not quite as fast. They don't give as high a resolution, but it depends on your monitor size. I mean, if you're trying to blow these things up, whether it's a phosphor plate or as a sensor, trying to blow it up on a 42-inch monitor in many cases will not look good. So again, you need to look at all these things in relation to your hardware also. And again, they come in all shapes and sizes. You're looking at an Optime unit on your left, the new Scanex from Air Techniques, which will take 4 phosphor plates at a time, so it will speed through the process along with a panoramic. You can use that. Let's see, we got a question. Are phosphorus storage plates more comfortable for a patient? And that's a good question, and I'm going to steal a line from a friend of mine, Dale Miles, who's an oral radiologist. If you've had film in your mouth, if you've had a sensor in your mouth, I don't think anyone will call them comfortable. It's just to what degree. Like I said, we use both in my office, and no one really complains. You use what you have to get the image on the patient. It's that plain and simple. None of it's comfortable. I mean, if you go back to film, you cut tori, it cuts into the roof of your mouth. It's just not comfortable. None of our imaging things are comfortable intraorally. So from that perspective, you try to minimize it for the patient, and we go from there. Is a PAN just as good as an FMX? That is another question that I would say it depends. What are we looking for? A PAN is good at diagnosing caries in most instances. The answer is no. A PAN is better for looking at jawbone abnormalities, things like that. But again, I think you're looking at two separate things. If I'm going to diagnose perio, I want an FMX. If I'm looking at a third molar situation, I want the panoramic film. So that's kind of how I feel about PANs and FMXs. But you can use, like I said, you can go from single units here, like the ScanX Swift on your right, where you're putting it, or the Optime on your left, where you're just dropping in one standard 0, 1, 2 size plate. Or, again, in the one in the middle, we'll go through all those sizes along with taking up to a panoramic. Sensors. You know, they should be, at this point, you should be able to directly connect them to your computer. You know, they can be USB. They also may be wireless USB connected. They are definitely faster than phosphor plates. They do give you a higher resolution, and they are, I would call it, slightly more diagnostic. Having said that, both sensors and phosphor plates I consider to be diagnostic, and I'm totally comfortable viewing both in my office. And like I said, we've got a few phosphor plate scanners in my office, and we've got various different sensors. I think there is no one-size-fits-all to any imaging solution, and if you can afford it, maybe look at two. It gives you redundancy in case something's not working, but again, they're all going to give you diagnostic images, and that's really what you're looking for. Do I think digital radiography is producing an enormous number of false positives? False positives to what would be my question. You're not going to get any more false positives because none of it is a test. That's really what it comes down to. Imaging is something that is viewed by a human being. With that, having said that, the decision to treat or not treat is based with that human being. This isn't something like a blood test where if you get a high number to something, that's what's making your decision. With that, you use digital radiography along with a whole bunch of other things that we can talk about. Things such as transillumination, these enhanced devices we'll talk about, but I don't know what the real reference there is to false positives. If the patient is a gagger, is a Panorex sufficient? Depends what you're looking for. If I'm looking for caries, a Panorex would not be sufficient to me in judging for caries in most cases. I know there's some panoramic machines out there now that you can take bite wings out of. Some of them work nicely when everything lines up and goes your way. If it doesn't, I wouldn't think they're that diagnostic. Go talk to the people who currently own them before you think that a Panorex might be good for checking out bite wings and caries. Check with some people who've already bought those machines and use them before you make that decision. So here was an FMX of phosphor plates. It's done. It's done quickly. You can see the area on that maxillary left second premolar. It's got a periapical radiolucency. You're missing some restorations there on the mandibular right. I find that these can be just as diagnostic in many cases as a sensor. We also then get to clinical photography. I mean, this is a big part of what I do on every new patient. In fact, this is probably the primary thing that I like about doing these exams this way, because in many cases, when you're doing something live, you have a tendency to miss something, and because you're spending seconds just looking at it. Whereas I think static images present a whole different level of viewing. Nothing's moving. I can really peer down into what I'm looking for and see and get a better idea of what's going on with that patient. So we get a better view of the teeth in my estimation. You get these static images that will now document everything that it is. So when a patient comes in, we're looking at something along the lines of there's all, we used to take those red and blue pencils and mark down, chart, and all those other things. We don't do that anymore. I have an actual physical looking, picture of what they have. I don't have to chart that out. I know how they came in, and that's really important. Here's another question. I'm just going to go back real quick. Is an FMX required on all new patients? No. Radiography is based on what the dentist determines needs to be done for that given patient. That is individualized to each patient, and you have to determine that for your patients. There is no one set. Everybody should get an FMX, or everybody needs a PAN, or everybody needs something every 5 years. That is based on what you see, and you make that diagnosis, doctor, as to what type of images you need. So we'll get back to your, let's see, we'll get here. What is the best and affordable imaging software that you recommend to go with the compatible practice management software for a new office? If you've got a new office and you haven't picked your practice management software, my suggestion would be to look at the imaging software at the same time. In many cases, you can get the imaging software from the person or the company that is going to sell you your imaging. Whether that's a sensor or the phosphor plate system. So with that, you want to be able to look at all of that imaging products, and then I would kind of back into my practice management system. Most practice management systems at this point are very good. All right? That doesn't mean I like them all. That doesn't mean I think all of them, including the ones I use in my office, are great. They all have their issues. But having said that, I think it's just as important to pick that imaging. So look at the hardware that you want, then look at the software that comes with it, see if that software works for you, and then see how best to integrate that with your practice management software that you currently own or what you're looking for. So let's get into the actual photography. I don't care what you use. You can have a big rig DSLR, you can do it with a point and shoot camera, and you can do stuff with an intraoral camera. I use all three. Whatever's handy, whatever convenient, that's what I want to use. Because if it's not convenient, you're never going to use it. So in the middle of a procedure, if you have to rip off your gloves to get out your DSLR, you're probably not going to take that image. Whereas if you can just reach for an intraoral camera at that same time, hey, you probably got that image. And we'll go see some of those images in a little bit. As to point and shoot, I think point and shoots work well. They work well because in many cases that's all you need for most patient imaging. They can be, relatively inexpensive. You get the shots you need, and you move on. And that's why here, color representation here may not be the best, but that's not what this was for. This was strictly for, just documentation. You can see chipped teeth, you can see missing restorations. We obviously in the operatory, we can build, we can make these photographs huge. Makes it easier for me to diagnose. I can see things. One of the things that I like to do is make sure I take an open photograph so we can look at the lower anterior teeth, because usually they're hidden in the closed bite. We want to see all the things that are going on, and in many cases, patients contribute to that discussion. They see something they don't understand or don't like, and they will pipe right up and say, what's that? And then we can have a discussion about it. But what better documentation can you have than what you see in front of you? This is actually how it appears when the patient walks in the door. No questions. And I will tell the story. I had a patient, young 20-year-old, who came through. We did her exam. She went to the hygiene. A couple of days later, came through it and complained that we had chipped her tooth. When she had left, she had called the office very upset that we chipped her front tooth. Mother called back very irate, and I said for them both to come in. It was fine. We'll check it out. If there's something chipped, we'll fix it. No charge. If not, well, I already knew the answer because I had the photographs. And sure enough, that chip was there before the patient ever came into my office. Well, Mom and the patient comes in, and I just pulled the pictures up. That was the end of it. They apologized. We all parted company, and all was well. And I said, if you'd like it fixed, we can fix it, and the cost would be this. And the wind-up was they didn't need it fixed, and we're happy as a lark. But, you know, that's because I had good documentation. Again, same patient, but now what we've done is we've added, I've seen things through my clinical exam, I've looked through intraoral cameras, and you can see the missing restoration, and you can see the little arrow that is on that photo, but we will get to another one here. Come on. All right, not working, but you can see the fracture on the upper right. How much better can I document this? Explain it to the patient, patient education. I mean, these are things that we're talking about. You want to be able to absolutely show those type of things right there. I mean, there's the fracture. There's the fracture line. In fact, when I took these images, you can see that I was talking about them because we did have the arrows in place. And if we have amalgams and things that are going on, or tooth needs a crown, what better way to do it than just see it right there and document it? We send photos for everything to the insurance company. We don't just send an X-ray, because in many cases the X-ray is not going to show anything. The X-ray obviously will show this missing restoration, but it's not going to show that fracture. If I put that in and say, here it is, there's no discussion. We know what's going on. Give them everything they want. And that's really important from a medical legal consideration. Before I pick up a handpiece, in over 95% of the times, I will take an intraoral camera photo. Because, like I said earlier, there should never be a discussion about the need for treatment. The discussion should be what treatment is needed. Then we can argue that up and down, you know, whether we need to seal something, whether we need to do a PRR, and again, whatever it is, an amalgam, a composite, whatever that treatment is. But we shouldn't really be discussing that the tooth doesn't need treatment. And one of the best ways to do that is with an intraoral photo. And that's what I use that camera for all the time, every single day. Think about that. Before you pick up a handpiece, you want to take an intraoral camera and snap that picture. Now, if you're doing a crown on a tooth that just had endodontics, you don't necessarily need that picture. If you've got this big, huge lesion that you can see on an X-ray from a mile away, you may not need that picture. But most of what we do are little and subtle things, recurrent decay. You may or may not see that. And from that perspective, you know, I want to make sure that I've got all my documentation. So then I usually go to the mouth, all right? It's time. We've gone through all our preliminaries, and you want to look. That's really it. Most diagnosis is done visually, and you really need to know that. But, you know, it's not your Explorer. It's not your radiography. It's not. It's your eyes in doing your clinical examination. And with that, I highly tell people you got to use magnification. No one's treating me without magnification. I can promise you that. If you thought you were going to treat me and you weren't wearing loupes, never going to happen. Because if you can't see it well, you can't do it well. And the same applies to diagnostics. You need to be able to see things very, very well. And with that, magnification is it. I started with 2.5 magnification and then went through from there to 4.8s. Added illumination, and now I walk around with 4.8 wireless illuminated surgical loupes. It's just one of the things that I can't practice without. That's a given. I can't practice without it. So absolutely magnification, I call it addicting. It's like crack. You know, I want more of it, and I've looked at even more magnification. I've even looked at the microscope, but I can't justify it. I don't want to do the learning curve, and that's really what it's about. I don't want to do the learning curve, but I really do believe magnification is the way to go. Because look at this. You know, this is what you see without magnification. Then you blow it up, and now you can really see what you're doing. And that's one of the things which will show at the end of this webinar why an intraoral camera is just a great adjunct to some of this magnification. Well, what about an Explorer? Okay, it's over 100 years old, and we've been taught in dental school that, we should use a Sharp Explorer. So, let's figure this out. All right? I want you to all vote on this one. So, do you use a Sharp Explorer? Yes or no? We'll give you a few seconds. And it's coming in. Okay, it's still coming in. And looks like we're about done. Anybody continue to vote? Come on. All right, we're going to close this out in 1 second. Okay, and I'm going to show you this. All right? This is quite different. It's interesting. Online, this is quite different than what I usually get in a lecture, which is the exact opposite. Most people say they don't use Sharp Explorers. Maybe that's because I get to look them in the face. Because Sharp Explorers, that's a pretty rarity. It's a rarity in my office. And the question is, what are we doing with these Explorers? That's really it. Because there's limitations to using an Explorer. Would you really want to take a Sharp Explorer onto a recently erupted first molar in a 6-year-old? Demineralization and how caries, is in this day and age in the United States is quite different than it was back in the time of G.V. Black, where you stuck an Explorer into a hole and, that was it. If it stuck, it was caries. It's not quite that way today, and in fact, there are a lot of studies that show that it doesn't add to the validity of the diagnosis. And this one goes back to 1991, and again, in my caries detection lectures, I show a number of similar studies all the way through, from the early 90s all the way to current. And, it's the kind of thing that, we have to, we have to realize. And, maybe we shouldn't be sticking Explorers in teeth. And Sharp Explorers only create holes in teeth. That's really what it's about. They create holes in teeth. There may be, times that you think that's necessary, and I'm not going to, sit here and question anyone's judgment as to what they should use. But I want you just to consider rethinking the, standard use of sticking a Sharp Explorer into a groove, and if it sticks, it's caries, because you may be creating an iatrogenic lesion. Back when G.V. Black started this whole idea, well, you know what? His choices weren't the same. They didn't have sealants. They didn't have bonding. They couldn't remineralize teeth. Think about that before you pick up that Sharp Explorer the next time, because really it's more about viewing than it is about whether something sticks or not. And that's one of the advantages of using an intraoral camera. There's lots of different ones on the market, some better, some worse, but it is what it is. And you want to be able to see things like you've never seen them before. So here's an intraoral camera picture. I mean, look at that. You can see right down, you can see it, right in here. Now, what we're going to do with that? Well, right there, that central groove, we can debate it. I know it's not going to show up in a radiograph, so if somebody showed you that radiograph of this tooth, you wouldn't see it. So how are you going to document it? Well, there's your documentation. Now, what are you going to do to cheat it? That's a whole nother story. Here's a question. A new Explorer is always sharp, isn't it? And absolutely, a new Explorer is always sharp. I agree. How long it stays that way is another question. Do you ever sharpen it? Probably not. When does it get dull? Probably when it breaks. So I like that. That was a good question. But if you stuck an Explorer into this groove, it probably isn't going to give you a lot of good information. So whether you think that this, just needs to be sealed, whether you think it needs to have a composite placed into it, that's a totally different scenario. But we need to know what's going on, and what better way to do it than looking right in to that group.
First, we were taught to look. Then,
so let's see what else is happening.
Reading radiographs. But minimally invasive dentistry now requires imaging, and we see caries like we never have before.
And that is the truth. We can see things that we couldn't before, and that's really a big deal here. And with that, we have all of these modern caries detection devices. We started out many, many years ago with a Cavo Diagnodent. I got these early on. It uses fluorescence. It was showing me things. It was diagnosing caries smaller and in ways I couldn't do it before. Then we've graduated to imaging devices such as the Spectra from Air Techniques, the Sopro Care, Sopro Life from Acteon, and then the one on the bottom there, a new thing from Canary, which doesn't use fluorescence, uses lasers and a whole bunch of other stuff to try and get you that information you need to make an accurate diagnosis. But this is how we're diagnosing caries in an occlusal in 2013. You don't need an Explorer. And my big thing is here, know what you're watching. Every one of us watch teeth. It's something we were taught to do. I'm not sure what is going on with this tooth. Is it caries? Isn't it? We'll watch it. We'll look at it 6 months from now when you come back. I mean, that's one of the things that we talk about, and I won't tell you I don't watch teeth at all, but now I can watch them in a different manner because I can quantify in many cases, or at least get the image that I want to keep so I can refer back to it. That's really it. What are we talking about in terms of, quantifying it? Well, I want to know what it looks like today so that I can go back to it and look at it again tomorrow. Does it look like it's getting worse? Are there numbers to actually quantify it so I can tell whether, we really are seeing something progressing or we have arrested caries? And that's not something we can do with just watching. Watching just is that. It's watching. There's no way to quantify it. What looks bad today may not look any different 6 months from now, but you may change your mind. You really need some way to quantify things, because our treatment decisions are totally different than they used to be. I mean, that's what it is. We have all these choices that, we never had before. What are we going to do? I mean, when I think about remineralizing a tooth, and I go back 10 years, that wasn't even on the list of things that was just an option to me, which it just didn't happen. But now we can do it. We can reverse the caries process. It's possible, and I've done it. So we want to know what we're doing and why we're doing it, and we need to quantify it and be able to go back and look at it, and you can't do that with an Explorer. You can't do that from memory. Hopefully you're seeing many more patients than that, so you can't. That's what we're talking about. So I talk about different kinds of things. What I call screening devices. Okay, that's an Explorer, it's a Diagnodent, it's Caries ID or CarieScan Pro. These are all the devices on the market right now. Then I have imaging devices, which is, just your plain old radiology, an intraoral camera, and these other, devices from various different companies. And then that Canary, because it has a camera in it, I kind of put it in between because it's kind of a screening device, treating device, and an imaging device. We're not going to delve into it too much, but, I just want people to know that it's out there. It's kind of somewhere in between screening and imaging. So then we get these kind of pictures, and if you look at the one on your left, that's an image from Carestream CS1600. The one in the middle is the Air Techniques Spectra, and the one on the right is the Sopro Life from Acteon. And as you can see, it's giving you information about caries. The only one, though, that gets to quantify it is the one in the middle. That is the Spectra, which actually puts this weather radar with numbers over the top of it. It does an analysis of the fluorescence. And with that, you get to have a better understanding, and you can actually quantify with a number what's going on with the caries. So that's quite a bit different than the other imaging devices. The other imaging devices, make you look at the tooth. You got to come back to that, such as the one on the right with the Acteon camera. You can record that image and decide whether you need to treat or not, but you're going to have to come back to that if you decide not to treat right now. You're going to have to reanalyze that image, and again, it's a little bit more subjective. And what these devices do is they use fluorescence. And in many cases, they're not actually looking at caries itself, but they're looking at something called the porphyrins, which are the bacterial byproducts of the strep mutans and all those other ones. And what they're doing is they can actually correlate the amount of the porphyrins to the amount of caries activity, and that's how it's done. So basically, fluorescence is you shine a light on something. With that light, it refracts back, it reflects, it transmits, all those things that light does, and we then filter it and can measure it. And that's how we can quantify what is happening with that tooth. So let's look at this in a little bit more detail. This is the Air Technique Spectra. So we have a tooth on the left. And we look at it, all right, and then we say, okay, where are we here? That doesn't look like bad. Those are a couple little grooves. Well, when we fluoresce the tooth, we start seeing things a little bit better. We start seeing that those orangey places, some of them are a little brighter than others, and then there's some grooves where, you can look at it and say there's really not much going on, such as this area right here where I'm kind of twirling the pointer right there. There's not much going on there. And if you correlate it back here, we probably would not have treated that. When I'm treating this tooth now, though, I now can quantify using Spectra what's going on. So when we look here, where it says a 1.2, that's not the millimeter depth. That's telling me I have enamel caries. And we're going to come up with the whole scale in a second. But I have enamel caries there. I can seal that. I can reverse it. Whereas we get these orange, we're much deeper. We're into dentin. And if you see here, we actually show the scale. So green, when it fluoresces, is healthy enamel. There's nothing wrong with it. And then blue is your, initial caries. Again, at that point, what do we want to do? Seal it? Remineralize it? Your choices are different. If you were to prep this tooth, what would you do? I mean, one of the things I would be looking at is right up here. I'd be sealing that with my composite after I went through all these grooves. I'd seal this little piece up here. I'm not going to take a burr through that. No reason to. And that's what this kind of information gives you. It quantifies it. It gives you good information to make good treatment decisions. And that's really what the benefit is. And again, we're looking at a tooth. What you're seeing on the outside there along the top here, that's just scatter noise, and you can just ignore that. But when we start looking at some of these other areas, we're seeing a whole different thing here. Do we go in and treat this, or do we seal it? We know we're going to treat in here because we've got, we're into dentin already. But here we're not. So maybe we just seal this area. Again, depends what you're looking for and how you want to treat it. And again, that's subjective. That's up to the treating doctor and what they want to do. There's a question about caries scan, which we're not going to cover, but what do you watch number-wise with a caries scan? I am not a big fan of caries scan, but you have to, they have their numbers that come with it. If you really want to discuss caries scan, I'll be happy to do that privately through email. But let's just say I had caries scan in my office. I still have it. I don't use it. We'll leave it at that for the discussion. So Acteon has something called Sopro Life, and they have a new one called Sopro Care. And one of the benefits to this is you can fluoresce the tooth. One of the drawbacks is it can't give you those good quantitative numbers, but they also have what they call, they have white light, a diagnostic mode, and a treatment mode. And you can actually use it, I call it as, digital caries dye. You can, instead of putting dye into the tooth looking for caries, you can use these devices to fluoresce the tooth, look at the caries, and remove the caries. at that point. It's very easy to do. It works well. There is a big learning curve to it, I will tell you that initially, but it's something that, again, helps you better treat the patient. I find it easier to use than caries detection dye. It's not messy. You just pick up a camera, look at it, see where it's red, decide how much of that red you need to take out. And you can see initially in that middle lower photo, all that red in the middle of it, that's all caries, but as it starts cleaning up, that doesn't look as the same type of red, and now what you're seeing is, adequate caries removal. And you can do that with a SoPro Life. Carestream has their own version of fluorescence in the CS1600, and again, it just kind of does this color overlay, and the color then, it tells you what's going on and how it should be treated. Fractures show up extremely well when you fluoresce them. I mean, you can see right down here where I'm pointing, wonderful place. You can see that fracture light up compared to up here where it's not really visible, and of course it's not visible on the radiograph. There's really no caries in it, that I can tell you from here, but much easier to find caries. Using any of the fluorescent caries detection devices, you can find fractures. Then the last part is I do a physical oral cancer exam. We do a look and feel, and if you want to know more about that, go to 6stepscreening.org. It will tell you exactly how to do a good oral cancer screening. White light. This site was put up by a friend of mine, Eva Grizel. She is a oral cancer survivor. She's got stakes in this. Okay, it was her life. She had stage 4 oral cancer. Thank God she's here to tell the tale. So if you want to know more, go to her website, but that'll tell you how to go do a good, thorough oral cancer exam. And then we look to enhanced oral cancer screenings. Whether it's a Velscope, an Identify, or the new Oral ID. There's also another one from Dentlight that you can use. And again, it's all using fluorescence technology so that you can look at different things, fluoresce them, and see what you see. If I see any pathology, I attempt to photograph it. All right? If I see something that doesn't look right, I want a photo of it, because that is going to help me determine what I'm going to do with that later on, because we go 2 weeks. If I see something I don't like, I wait 2 weeks, I bring the patient back and see if it's disappeared. In most cases it has, and there's nothing to treat. But if it hasn't, like in this case, I then, refer this case out for further evaluation. Again, as I said before, I want to document before using a handpiece. Anything I want to do, whether it's a broken tooth, whether it's caries, if it's not easily seen radiographically, and then in most cases, even if it is, especially for a crown, I'm going to take an intraoral photo of it because I want that documentation. Again, pathology here doesn't look like much under white light, but as you can see, there is some enamel caries starting. What do you want to do? That's the question, and it's documented now. Patient education from all of these images, real important, because as you see, 83% of learning is done visually. So, if you can show this stuff to the patient, show it to another doctor, whatever you want to do, we are going to educate people on why they need treatment and how best to treat them. I don't think any device, is going to give you an absolute. As you saw, if you saw those two little, in the previous slide with that enamel caries, would it matter if you were looking at an 80-year-old? Or would it matter if you're looking at an 8-year-old? I think it might. So, again, you have to make the decision. You have to decide what the diagnosis is. We want to use everything at our disposal to make an accurate diagnosis. But where is that diagnosis made? It's made in your brain, doctor. It is not relegated to someplace else or to an instrument or to a reading on any of these things. Use good Canberra principles and make the diagnosis in your head, because you get to take into account everything else that's going on that device can't. Caries index, restorations, home care, All of those things are done in your brain, nowhere else. So you get to assemble all that information, come up with the conclusion, make the accurate diagnosis, and that's where we're at. We have all the records, we have everything that we need, it's documented, and then you get to move on from there. Because a lot of these things, here was a spectra image, but look how we improve treatment. I can actually see composite now. I can differentiate composite from tooth. In many cases, when I'm prepping a tooth, I have a problem with that. And if they match the color, you can't see it. Using something that fluoresces does that. Beyond that, again, sometimes I always pick up an intraoral camera before I'm finished, even with my loupes, because sometimes I miss something. I can see, a flash, something that needs to be smoothed. Those are the kind of things we want to look at. There's a little bit of an overhang that needed to be taken care of. Those are the things that we need to be able to see. In many cases, just even with my loupes, I miss them. So with the imaging, I see them on a big screen monitor, and I get to, go back and improve my treatment. So we go on to some questions. If you've got questions, start typing them in. I'm happy to answer them. Here's one. What do you find to be the typical learning curve with these technologies and the caries detection aids? Well, I think that in some cases it's quite short, and in some cases it's a little bit more involved. When we're looking at these devices, we want to see what we're looking at. When we're talking about a learning curve, one is you need to make sure that you have the teeth cleaned and isolated. You don't want it in a pool of saliva. All of these devices come with a little hood that goes onto the camera, and it gets placed over the tooth because you want to keep outside light away. And with that, then you're going to get the information come back to you. So, isolate the tooth as best as you can. You can use, in many cases, it's just simple retraction. In other cases, you may need to use some cotton rolls. You want to make sure that the grooves are clean. That's real important. Grooves need to be clean. They can't have lots of food in there. And, you look at them and you check them. And you look at it against a radiograph, and you look against everything else that's going on. And the learning curve for some of these devices is quite short. I think using Spectra, it's quite short. In using like a SoPro, it's a little bit longer. If you're using it for caries detection, I say it's even longer for both of them, because you have to understand when to start and when to stop, because you can excavate a tooth just using these kind of technologies. Well, let me see here. I got to go back. All right. What digital systems do you use? Okay. In my office, and this by no means is an endorsement, I have a Soridex Optime unit. I have a Air Techniques ScanX and a ScanX Swift. I have EVA sensor. I have a Sopix sensor from Acteon. That's what I'm currently using in my office. How often do you study models? I use study models when I think the case is appropriate for it. And that's another thing. You can take those study models and you can photograph them. I do that if I have to send the study models into the insurance company, or if I want to, sometimes I need to take home the image. I will actually take home photographs of it. We'll photograph it just as if it was, a patient. And I put that into the imaging software so that I always have it. But I take it as needed. Do you find caries detectors like SoPro much better than the inexpensive caries detector solutions like Seek? Absolutely. I find those to be messy. I don't feel they're as accurate, and I can't go back and monitor anything with them. So I think those days, at least in my practice, those days are over. What are the typical price point of caries detection aids on average? Caries detection aids usually are somewhere in the $3,000 to $5,000 range for those cameras. You can get less expensive ones. Diagnodent is probably somewhere just below that $3,000. And again, depending on what you're looking for. But the imaging devices are going to be somewhere in the $3,000 to $5,000 range, and they top out with the Canary unit, which is somewhere around $18,000 US. So that gives you an idea of costs. When we're talking about sensors, phosphor plate systems, Again, we run the gamut from plate systems can be anywhere from like $5,000 to $15,000, and sensors are anywhere from just a raw sensor could be somewhere around $5,000 up to $10,000 to $12,000. Again, base things on needs, not anything else. So does anybody else, any questions? We're going to call last round for it since I don't see any new ones popping up, and it shows me I got about 15 seconds left. So if that's it, it looks like we're about it. So I want to thank everybody for spending an hour with me this evening. For all of you around the world, you have a good day today and a good tomorrow, and thanks for coming by.